Good evening, ladies and gentlemen. I would like to welcome you to this workshop, the post-workshop of the 24th Düsseldorf Interventional Endoscopy Symposium. And I'm glad to host this session. It's a Aohua workshop, and Aohua is a new company that just launched a very exciting new endoscopy system. And we would like to present you a few cases, in total 6 interesting cases. I'm the moderator, and I'm doing this together with 2 colleagues. One is Professor Lopez from Portugal, and the other one is Professor Madachi from Hungary. And we are very excited to present you interesting cases out of their daily practice and also show you the features of the new endoscopy system. So I would like to start without further ado with Professor Lopez, and he will present you in total 4 interesting cases from his hospital. Luis, please.
Hi, good afternoon. It's a pleasure to be here presenting 4 cases. I'm going right away to the first case. In this first case, I think let me see, okay. This is a patient with 70 years old patient, in which in 2016 he had a colon cancer, and in 2021 he did a follow-up colonoscopy in which it was diagnosed 12 millimeter flat lesion in the distal ascending colon. Now we are seeing the colonoscopy. At the beginning, we were with a little bit of difficulty in finding the lesion. But as you can see, the quality of the image are quite good. Now we can see the image of the flat lesion so it's a flat lesion in the ascending colon. And now we are demonstrating our AI platform that we are developing. As you can see, you see this square. It's to detect. So it's the system is detecting the flat lesion, as you can see, in real time. So we call this in AI the detection of the lesions. So it's one of the main features of these systems. First, the system must detect, and then it must make a mask before it can do a virtual biopsy, which is the goal of the system, is to try to differentiate the type of the polyps. But we are just demonstrating the capability of detecting the lesion in real time, as you can see.
Luis, the numbers you can see, is this the likelihood for a polyp? You can see at the numbers are counting on this on the top of the square.
No, this is trying to this tell us the accuracy of detection. So there are some measures to now, as you can see, we change to CDI, which is people that are familiar with for instance Olympus with the NBI. It's a little bit similar. You can see the quality of the images. You can see the vessels.
Very nice.
We can try to characterize the lesion and try to predict the histology. This is a peculiar lesion because if you look at the surface of the lesion, you cannot see the microvessels. Okay, so it's not clearly a type 2. We don't have yet, because this case was done a few days ago, we don't have yet the histology, but we can be a little bit worried about the histology, as although it is a small lesion, as you can see, you cannot see the normal vasculature in the surface of the lesion.
Totally agree. It looks a little bit dodgy. It could be a high-grade dysplasia or an early cancer even. Do you agree?
Yeah, I completely agree.
Yeah.
Now we are demonstrating the resection of the lesion. We performed a normal mucosectomy. We inject, as you can see, saline with methylene blue, okay, as is our policy in our department. So usually we use methylene blue to see clearly the submucosa. And then we use a regular snare, a monofilament snare, and we try to capture all the lesion carefully, although we have the safety of the submucosal cushion that we performed initially. We use Endo-Cut usually, and as you can see, you see clearly that we cut and we have submucosa because it's full. And then we have the lesion, and then we could use the snare, but because it was a video to show in this course, we use a Rosnet to capture and it's the case. So as you can see, high quality images, and the system works very well indeed.
It was really nice to see the image quality and how nicely you can appreciate the surface of the polyp and the mucosal structure. Yeah. Yes,
I completely agree. And with the CBI, I was impressed with the quality of the CBI.
Absolutely.
So it's very high quality. We can see the vessels, great definition. We can use magnification in the system. I didn't show, but we can have two images. So with the system that I had in my department, we can have at the same time CBI and white light. So we can compare both images, which can be quite helpful to make the diagnosis and to delineate the strategy. Yeah. I think we can pass to the second case. I asked someone to pass because I think I cannot pass to the second case. Okay. Now the second case. I have the second case is a 58-year-old female with no personal history of cancer or family colorectal cancer, no medications. She did a fecal blood test in the Portuguese screening for colorectal cancer, and it was positive. So she was referred for colonoscopy. And now, as in the previous case, I show our II platform. In this case, we can see a different polyp, a pedunculated polyp, clearly an adenomatous polyp, and you can see the detection. Okay, the square. The square is to detect the polyp, although it's quite easy for a human to see that it's a polyp. I think that's awesome that the machine can say this is a polyp, and then we'll do something that is very important to the system is to do the masking. Okay, we call this segmentation. The objective of our system is not detecting and segmenting. The objective is to do virtual biopsy, so try to differentiate, but it's a precondition, okay? And now with CBI, also, you can see clearly, if we think about NICE, we can say that it's a type 2, maybe. I think you agree, Oliver, or not, a type 2 polyp?
Absolutely, I agree clearly. Yeah, it's a nice too.
And as we can see, it's the quality of the images are impressing again, and we can see we can switch between CBI and white light using magnification. Sometimes I use a lot of magnification to try to do. Now we can see that it's a pedunculated polyp. At the beginning, we cannot see, so it's not a big polyp. Usually we don't inject, but this patient it took aspirin. Although aspirin doesn't increase the risk of, we decided to inject. As you can see, we inject with methylene blue again, and a little bit of adrenaline. Although it's up to the endoscopist to decide. In this case, it was not me that performed. Usually, I don't inject in this type of polyps, which are not so big. But okay, we did the injection, and then is the usual technique of doing a polypectomy, snaring, and try to put the snare at the middle of the stalk. And cutting. In our case, usually we use Endo-Cut always. Or nowadays we have also Olympus, the new system from Olympus, the electrosurgery machine, which is similar to Endo-Cut. So We use Herbe as most of the I think most of the gastroenterology departments. And as you can see, we are in the middle. So this is a good case for residents. I think so to show how we do a polypectomy. Not very difficult, but as you can see, again, the methylene blue, we can see clearly that we are in the submucosa. In this case, it was easy. And we have some bleeding, okay? Despite the injection, we had some bleeding, and we decided to put a clip, okay? In this case, 2 clips, because one was already inserted, and which is nice to demonstrate that sometimes we are not sharp at the first attempt.
So some people clip before they resect. You usually just resect, especially a polyp with such a small stalk or a thin stalk. I think it's safe to just resect and then clip if needed. Yeah.
Completely agree. And sometimes, for instance, if we think we can do with an endo-loop, we can use an endo-loop. But usually, even if it is big, I inject, and then after, or I put a clip. Usually I put a clip, but I can put an endo-loop, so it's my strategy. I inject, but I usually don't do. In these cases, if it was me that performed, probably I wouldn't inject.
Yeah, agree.
Not needed. Yeah. Now I think we can go to the third case. Okay, this is a different case. So this is a case from a very old patient, 94-year-old female with a distal esophageal adenocarcinoma with dysphagia, and it was proposed for the usual for stenting, for palliative treatment, of course, due to age and to the advanced disease. You can now we pass. So this is a special case. Usually, at least in my department, most of the cancers in the esophagus I cannot pass with the scope. Okay, this is not the usual thing here, at least in Portugal. But in this case, we could pass with the scope. Now we are in the stomach. Of course, you can see an ulcer. You can see clearly the images are. Although the objective of the procedure was to insert the stent, we can see we have other images, other things that we find. Here, we put a clip at the distal end of the tumor in the cardia, and then we put a clip in the proximal end. Then you can see the wire. We let a wire. This is a Savary wire, and then we insert the stent using the fluoroscopy endoscopic combined technique. Although we could insert just using endoscopy, but in our department we almost always use the combined technique because we do this in a fluoroscopy room. We have fluoroscopy. That's the main reason. We have fluoroscopy, so we use fluoroscopy. Although it was possible because we passed the lesion, and it was safe to pass the wire because we passed we transverse the stenosis with the scope. And then that's the usual technique. We use partial covered stent, which is, I think that's standard in the palliation of esophageal cancers. We can use 18 or 23 using the brand that we use. Usually we use 23, except in the proximal esophagus, in which we use 18 because of the risk of compressing the bronchial tree. And the delivery system, it was distal to proximal. And nowadays, even if it is a proximal esophageal cancer, with taking care, we can use proximal distal to proximal. If it is possible, if you have the skills, you don't need to have proximal to distal. We cannot prove, but it's a question of the preference of the endoscopist. And
totally agree.
The technique is the regular technique. Be careful because you know that the stent tries to when it opens, the system goes distally, so you have to push. You have to pull. and it was an easy case because we could pass we could pass the tumor, because in most of the cases we are not able to pass. And in that situation, I don't know what is your opinion. If you cannot pass with the scope, you have to do the combined technique. I don't know if you agree, because it's not safe to probably you won't have problems, but there is theoretically a risk.
Yeah, I totally agree. If you you aren't able to pass, even we sometimes use a pediatric endoscope, but if we can't pass, we always use fluoroscopy. Yeah, agree. Yeah.
But I agree. If you can pass using, for instance, as you say, a pediatric scope, probably in that situations there are more cases in which you can pass, and in that way you can deliver a stent in a normal endoscopic room.
Yeah.
Because in our department we have a big fluoroscopy room that we can go whenever we want.
Yeah. Why not?
Say, okay, we have fluoroscopy, we have technician here,
yeah.
And and so it's our policy. We learn. Sometimes we learn in a certain way, and we keep the way, and we keep it. Okay.
Yeah, it's not wrong. I think there are two ways you can do it, and at least at the end, the results is what is counting. So you stented the cardia. Do you usually use stents without a anti-reflux valve, or do you use your experience?
I never, to be honest, I don't. There are a lot of papers. There is no. We cannot say that using, although theoretically using a stent with an anti-reflux valve prevents reflux, and it could be helpful for the patients. Our experience, I have that. I think in most cases is more theoretically, that in reality it is true, because we are talking about esophageal cancer, not benign diseases. And we don't have that sensation that if we breach the cardia, the patient will have a less quality of life because we didn't use an anti-valve. And to be honest, we always use regular stents. Okay, we try, if we can, to preserve the cardia. Not in this case, but if it is in the middle of the esophagus, we try to choose a stent with a length that doesn't pass the cardia. But if we have to pass, we pass. And I don't use that kind of stents. I don't know. What is your opinion?
I totally agree. So the literature out there is not conclusive. So there are papers that are for and the anti-reflux stents, and though there are also there's some evidence against it. So it's not really conclusive. So you can do both, I think.
And if we look to the big brands of stents, the big brands, they don't have anti-reflux barriers, most of them.
Yeah. Okay.
Thinking about the two most important, probably they don't have. Yeah.
So I think we can now move to your next case. So I would like to encourage the audience to ask questions if you have any over the chat function.
Now this is a case of a patient. This is a patient with an 84-year-old male, in which in 2017 he had a prostate cancer. He did radiotherapy, and he presented 2 or 3 years after with recurrent episodes of hematochezia. Okay, and in this case, he came to our department with rectal bleeding, with several episodes of rectal bleeding and anemia. So we knew in advance what we could expect from this patient. And this is especially to show a case of radiation proctitis. I think everybody in a gastroenterology and endoscopy can make the diagnosis, which is quite easy with this history, with this localization, with the typical aspect of these vascular ectasias in the lower rectum. Okay, and we can see that in the past he had already done probably some coagulation because he has some scars. Okay.
So So you just changed the mode of your image. I think you changed to another mode where you
between
could
CBI and magnification.
Yeah.
CBI and magnification, and you can see quite well the vascular ectasia, pale mucosa, so things that are typical of chronic radiation proctitis.
Yeah, very nice. Yeah.
Although we can discuss if we should call it proctitis, because probably there is lack of inflammation, but it's a little bit misleading the term. But here, especially, is to see the high quality images that we can have with this system, using white light with magnification, using CBI. But CBI is very good to see the microvasculature because of the type of wavelengths that we use to filter the light, which can detect hemoglobin, and so we can see the microvessels, and we can see clearly the microvessels.
Yeah, very nice.
Quite distinctly.
So it seems like there are a few scars in the rectum already. Was there a previous treatment?
Yes.
Okay.
In the past, not more than 1 year. More than 1 year before, he did some sessions in another hospital, and we can see clearly the scars of the. Yeah, completely agree. And now we decided to perform APC in this case. Although we can discuss, because he had already done APC probably in the past, and he has a lot of vascular ectasias in the distal rectum, and we can discuss if we should using APC in the 2 centimeters above the anal canal, if we should or not use APC there. But I think it's theoretical because we can. And now in retroversion, just to see that the images, to see more clearly in the lower part, just immediately above the anal canal, we did the usual maneuver of doing the retroversion, and we can see clearly the vessels. I think the quality is quite good, and the other thing that we can stress out is that the colonoscope, we can do retroversion quite easily. As you see in the first video, that we in the cecum, we did retroversion in the cecum. So not only good images, but good maneuverability of the scope, which is important for therapeutics.
Yeah.
And then I have just a little bit the beginning of doing APC. We have not all the treatment, but we then did just the initial part of the coagulation using APC, and in this case, smart APC. The mode it's a mode in the Olympus electrosurgical unit.
Okay.
It's not forced.
Okay. Different. Yeah.
And 40 watts, and we have the effect, and we increase the effect until we see. We can put even in this case 100 watts. I'm joking, because it's the APC that will adjust the potency. Okay, It's different from the fourth. Although sometimes it's quite difficult. He is so smart that he doesn't allow us to do it's too smart, and sometimes it's very difficult to get the effect. But I'm just because usually we have experience with Urbeck, and in this case it's a different electrosurgical unit. And
so great, thank you very much for those very nice cases, interesting cases, really nice. And I think the image quality you showed was really impressive, and also your skills to place a stand and everything. So thank you very much for those cases.
Thank you, Oliver. Thank you.
Now we can move to Professor Madachi from Hungary. He also prepared 2 very interesting cases, and we will start with the Barrett's case, as far as I remember.
Thank you, Professor Prech, and it's a real pleasure to be here with you in this symposium. First case is a 76-year-old male patient He had some things in the medical history, but no GI disorders. And then he presented in loss of appetite, epigastric pain, and fecal blood test positivity as a signs of acute obscure GI bleeding. He has some positive family cancer in lung cancer in his father. And previously he had gastroscopy and colonoscopy a long time ago. And now he had a negative colonoscopy before this examination. During the presentation, first I will show you the capsule endoscopy investigation. This is a special capsule endoscopy investigation with a magnetic controller. And I just wanted to show you that we visualize some abnormalities in the distal esophagus and some signs of gastric metaplasia. And now you can see the hiatal hernia. We also have nice pictures from above. We have a special technique how to hold on the capsule with the magnet in the distal esophagus. Actually, it was a little bit longer in the hiatal hernia here than in above the Z line. And now this is a last part of the gastric examinations when we are doing the retroversion view with the magnetic capsule. And again, the abnormal cardia in the hiatal hernia was visible. Actually, during the real life, we first did the gastroscopy and the colonoscopy, and secondly, we did the capsule endoscopy because there was no real obvious explanation of the obscure bleeding. But I wanted to show you that in some cases, at least, it's possible to have a visualization of the distal esophagus, and probably it could be a good way to screen Barrett esophagus later on. And this is the endoscopic view of the new Aohua system of AQ 200. And you can see now the distal esophagus. This is the hiatal hernia just under, very large hiatal hernia. And from above, some gastric tissue coming up. And in the retroversion view, you can visualize the hiatal hernia from under. And then we went to the Barrett segment. It was a 3 to 4 centimeter long circumferential Barrett segment with 2 centimeter long non-circumferential longitudinal segments as well. And now I switched on the CBI mode. You can see here in the upper end some Paris type 2C or B type of little bit exulcerated and irregular lesion. And this is the distal end of the Barrett segment. So we try to visualize parts of the Barrett segment which could be dysplastic or could inherent high-grade dysplasia. So it's very important to look carefully, and we will change and switch to normal high-definition mode, and also this CBI mode and the hemoglobin enhancement mode as well. And then we will take biopsies. So this is the part where we take biopsies. Normally, in this type of cases, in my unit, I like to inherent to the regular circumferential biopsies every 2 centimeters of the Barrett segment, and also do extra biopsies from those parts which is suspicious for high-grade dysplasia.
This is what you're doing now. You're taking biopsies from the suspicious lesion,
Actually, I had a feeling that it could be even more, so it could be an intramucosal cancer.
Absolutely agree,
And then it was done 2 weeks ago, so we had the final histology from all of the segments and from also from here. And according to our expert pathologists, from the biopsies, there were only low-grade dysplasia and of course typical specialized intestinal metaplasia and the long segment Barrett. So that was the first histological diagnosis in this case.
So interesting that you only found low-grade dysplasia. So what's your plan now? What are you going to do with this patient?
Because there was a obvious focal lesion of mucosal irregularity and also abnormality on the pit pattern and the excavation, a little excavation. We would try to refer this patient to a Barrett Center in the Szeged University. I have a very good friend, Professor Fender, who will do a band ligation buccosectomy of this special part and re-evaluate of the local pathologies, because in the university there is a Barrett expert pathologist as well, and they will re-evaluate this case, and then they will see exactly whether it is a high-grade dysplasia or an intramucosal cancer, because it will really influence the further measures what to do with this patient.
Yeah, totally agree. Yeah, that's the right thing to do. So when you have a visible lesion and a low-grade dysplasia that is confirmed, so you always should perform an endoscopic resection. And I think it's a very good choice to send it to a Barrett Expert Center. Very good, nice. So let's come to the second case.
Okay, this is a second case. If you could start the video, I need to start. Yes. This was just a 60-years old female patient who had been referred of colonoscopy. He has some history of cancer in his family, so it was just a screening colonoscopy and the relatively normal laboratory tests in the case here. So we will show you a part of the colonoscopy, and we also show you a prototype of an AI system we developed during the last 5 or 6 years. So this is again our high definition endoscopy system with AQ200, and then you will see subcentimetric polyps here. First, we will show you with the special CBI mode and hemoglobin enhancement mode, and also now you can see there's some digital zooming. So we will try to visualize the pit pattern. You can see very nicely the pit pattern, and this is our prototype. Actually, you can find it on the net, so you can play with it. And if you upload an image, what we did here, and there is no polyp delineation automatic system here, so you have to delineate and the polyp and show the system the borders of the polyp. And now this is the evaluation. Of course, it was an adenoma, and the red color is meaning that this is an adenoma, and you can also see an accuracy of the histological prediction. What is the chance that this is an adenoma? If it's 1, it's 100% sure, and if it's 0, it's 100% sure this is a hyperplastic polyp. This is another polyp here. It's again a small polyp. All of these small polyps, according to the guidelines, should be removed with cold snare polypectomy. Again with the hemoglobin enhancement mode, and now the compound band imaging mode, you can see the polyp surface. As a relative expert in this area, I think I'm absolutely sure as an expert that this is also an adenoma. In our opinion, if we have smaller polyps than 3 millimeters, we need a zooming technology and also a chromoendoscopy mode to be sure and have high accuracy from the expert view to differentiate between hyperplastic and anastomosis polyp. This is again how we can use our AI polyp characterization mode, and you can see that it's again saying it is absolutely sure this is an adenoma, but the chance is not 100% here. And now we will try to go closer and closer and showing you the vascular pattern here. You can see that in the majority of the pits, you can see microvascular pattern and capillary pattern. So again, this is also another adenoma. And finally, I will show you a little bit larger one at the end of the video, where we will do a mucosectomy. So a little bit advanced endoscopic technique. Any question before the
so this is, you're showing now very nice images. So this is a digital zoom?
Yes.
Yes. Okay.
Yes.
Very nice. And this is the hemoglobin enhancement mode where you can see a little bit more reddish. And now this is the CBD mode where we can, it's like an NBI. Yeah.
Yes, we want
very nice image. I think it's brilliant image quality. And regarding to your AI system, so it's on a computer, on a separate computer where you can do the delineation and then the analysis, or is it online on your endoscopy screen? How is it working?
Now the idea was that we wanted to develop a web-based and company independent system, and now it's running on a computer, but you can enter from the web. So there is a website you can go and you can freely analyze your polyps if you want.
Yeah, that's nice.
This is the last polyp. First, we will show again the system. Of course, it's a little bit larger and little bit flat or subpedicularity adenoma. Absolutely sure. The system is very sure this is an adenoma.
Yeah, he should.
And then we will do a mucosectomy here just to show. Of course, again, a cold snap polypectomy would be a good option here because according to the ASGE guideline, even larger polyps than 1 centimeter could be resected with cold snap polypectomy, but mucosectomy is also an option, and we also use airway systems, and we use Endo-Cut mode. And with the Endo-Cut mode and the under injection with saline, actually we don't see real post-polypectomy syndrome. So I don't have in my mind with this technique any late complications due to the hot polypectomy. I don't know what is your opinion. How frequent?
I totally agree. What I usually do is polyps up to 1 centimeter cold snare and larger than 1 centimeter I do usually in the injection. We are participating in a prospective randomized trial where we also perform cold snare resection of larger polyps, larger than 2 centimeters. And our experience is quite good with that, but I think we still have to wait for the results of piecemeal resection of larger polyps with cold snare.
Back to the AI development, we now have 2,000 subcentimetric polyps in the histological verified database, and we have 20,000 pictures from these chromoendoscopic pictures. And what we did, it's only published in abstract, but we asked our experts to watch the polyps and with different modes, and with zoom and without zoom, and then try to assess, define the histology compared to the real pathologist's opinion. And And then we also apply the AI to do this decision. And in my unit are experts who has a very high polyp detection rate and very good colonoscopy experts. They have only 85 to 90% of accuracy, defining the histology, whether it's neoplastic or non-neoplastic polyp, in a large database, which is where is the polyp is when the polyp is smaller than 5 millimeter. And we also see that zooming or digital optical zooming helps a lot to improve the accuracy.
Very nice. So interesting that we saw two different AI systems that are independently developed, not from a company, but from institutes or universities. So this is very interesting to see. Yes, so we are at the end of our cases. Thank you very much for you both showing those very interesting cases, and also the daily work with the system. I think we can really nicely appreciate the high quality of the images. It's a HD, full HD image quality, and we have really nice features like the digital zoom and the CBD image. So like NDI, the CBI plus we can use to better appreciate the mucosal surface and vascular structure. So very nice, excellent image quality and really nice cases. So I would like to thank you both for doing this workshop together with me. And I also would like to thank Aohua for sponsoring this workshop. And thank you very much. I wish you all a good evening and thanks to the audience. And I would like to thank you and say goodbye.